Ross and I are going to talk today about surgical site infections, prevention and treatment. I'm not the surgeon, she's the surgeon, so she has a disclosure and I don't. So today, at the end of this session, you will be able to identify strategies for the prevention and treatment of surgical site infections. And we're going to raise some awareness of some controversies in the current literature about surgical site risks. And the challenge for you is to maybe initiate some improvements related to this evidence. And we're not just going to get into the evidence, but we're also going to explore some of the team approach and how we can change the environment to improve patient outcomes. So the Canadian Patient Safety Institute states that surgical site infection is the most common healthcare-associated infection among surgical patients, with 77% of patients' deaths reported to be related to infection. So it's certainly important that we improve patient safety by reducing the occurrence of surgical site infections from happening. So the Canadian Patient Safety Institute also provides us with some current statistics from their audit in February of 2016, and they identified 2 to 5% occurrence of inpatient surgical site infections. They also report that 60% of these are preventable with the implementation and adoption of guidelines. Certainly having surgical site infections has adverse outcomes in terms of increasing length of stay, financial outcomes, morbidity, mortality to the patients. So a lot of negative outcomes associated with surgical site infections. So it's underscored here that these are stats just from inpatient surgery. So when you think about all those outpatient surgeries that are happening, a lot of these aren't captured in that data. So these numbers are significantly going to be underreported. And so the Center for Disease Control provides us with some standardized definitions of what a surgical site infection is. So it can be a superficial incisional surgical site infection, which can occur within 30 days. And this is only going to involve the skin and subcutaneous tissue. And the patient is going to present with one of these signs or symptoms. The deeper we go, we have the deep incisional surgical site infection. This can occur with a bit longer duration, from 30 to 90 days, even longer than that. And this is going to involve the deeper tissues. And the patient is going to present with at least one of these signs or symptoms indicated. And the deeper we go, we have the organ space surgical site infection, which can occur even longer duration. And this is going to involve any part of the body, deeper than the fascia or the muscle layers. And the patient is presenting with at least one of the following: of purulent drainage, cultured organism, abscess. And this can occur, of course, in various areas. These are just a number of examples of that. So the CDC definition is the most widely used and comprehensive definition, but this also system only gives categorical data, which really does not reflect the severity of that surgical site infection. So you're probably all familiar with the categories of patient risks or surgeries, anywhere from clean to dirty. And once again, this is a system that was based on the theoretical division of the potential for the development of a surgical site infection. So therefore it is flawed because it doesn't include the patient risks or even any use of prosthetic material. So keep that in mind. So the rest of this presentation is going to continue on with a discussion as to what's going on before surgery, in surgery, and post-op surgery for our patients. There's, of course, some predictive indices. So if patients have any one of these, that puts them more at risk for developing a surgical site infection. But we can also look at it in terms of, okay, what are the extrinsic and intrinsic risks that our patient presents with? And of course, a lot of our patients might be elderly. We have a lot of sicker patients, and of course, all the chronic diseases and all the medications. These are things that just add up and increase that risk level. So we can look at the patients, number one, but we can also look and see what's going on in terms of treatment, and these are certainly a number of factors that will increase the risk of a patient developing a surgical site infection. In terms of, what is the evidence for prevention? So we know in the surgical world that we use bundles to standardize our care, so we don't basically forget anything and reduce some omissions in our care. So antibiotic prophylaxis, you're probably all familiar with, is a standard of care before surgery takes place. In terms of hair removal, we know that preoperative hair removal has been associated with an increased risk for surgical site infections compared with no hair removal, and lowest rates of surgical site infections have been observed when hair was just removed prior to the incision. So, of course, the damage caused to the skin by shaving too long before surgery is going to encourage the growth of organisms. So, normothermia is, of course, keeping the body temperature constant before, during, and after, and Karen is going to talk to that a little bit more detail shortly. And also another standard of care is prepping the skin with skin preparation to reduce that bioburden on the skin surface, and typically that's done with something like chlorhexidine with alcohol. Patients who are at nutritional risk, that's going to correlate with poor postoperative outcomes. We know that albumin is an indicator of how well patient wound healing is going to occur, but serum albumin has not been clearly defined as an independent risk factor for surgical site infections. Beefing people up with food and drink, so to speak, before has had some mixed results in the literature in terms of our patients who are maybe bariatric and who have an elevated body mass index. That is a predictive risk factor for surgical site infections, and that might be related to impaired wound healing and decreased tissue penetration of the administration of prophylactic antibiotics. But what is important is that the patients at risk are identified at an early stage with a validated nutritional risk scale, and certainly under the supervision of a nutritional support team. So one of the most widely accepted strategies for surgical site infection prevention is antibiotic prophylaxis. And you can see from this slide that administering antibiotics within a certain time frame of 30 minutes to 60 minutes is going to have a good impact on reducing surgical site infections. So the goal for antibiotic timing is to achieve serum and tissue antibiotic concentration that exceeds the minimum inhibitory concentration of the majority of organisms likely to be encountered at the time of the incision and for the duration of the surgery. So, this is important, and if it's not done, you can see that it affects outcomes for sure. One of the controversies in this literature is that Hahn and colleagues concluded that surgical site infection risk varies by patient and procedure factors as well as antibiotic properties, but they say it's not really significantly associated with prophylactic timing. So they say adherence to the timely prophylactic antibiotic measures is not bad care, but they're arguing that there's actually little evidence to suggest that it is actually better care, but it is the standard of care. When I did this review, I wanted to look and see, what are the patient's experience of surgical site infections, and not a lot out there about that, surprisingly, but patients' understanding of surgical site infections is low. They have a low awareness, they have a low concern, they have little understanding of that. So the argument is a raised profile may increase compliance and preventative interventions for earlier assessment and treatment. So here's about involving the patient much more in terms of surgical site infections. So here's the Canadian Patient Safety Institute audit. And this is what they recommend if you're doing surveillance and auditing infections in your area. If you have less than 20 people per year, then you're going to sample all of them. If you have 20 to 100, then you're going to sample 20 of those patients. And they recommend not using this audit for trauma patients or emergency or surgical patients. So that audit contains certain questions on there. For checking off, is your area doing pre-op showers or baths with soap or antiseptic, which there's really little evidence to support. What type of solution is your area using for cleaning intact skin? Are you using the prophylactic antibiotics timing appropriate and redosing as appropriate. What type of hair removal are you using? Is there hemoglobin A1C in normal levels, which Karen will talk about shortly too, as well as normothermia. So that's kind of what the questions are included in this CPSI audit if people are interested in doing that. So the results of that audit that were done, as I mentioned, in February of 2016, only 52 sites were involved in this audit. So they looked at just over 2,000 cases. And once again, these are only clean class 1 and class 2 type of surgeries. So not the complicated surgeries that we're looking at. And you can see the results were 1,028 people were getting pre-op showers, and there was no response from the rest of the group. People are using antiseptics for cleaning intact skin, but some of them are not recording that information. So you can see how we're not adhering to some of these guidelines. In terms of how are we doing with surgical site infections over the years? Well, to me it kind of looks like up and down, and we're not preventing them 100% from happening, and there's probably a number of factors contributing to that, which we'll hopefully summarize at the end of this presentation. Of course, monitoring challenges for surgical and site infections. One of the challenges is recognizing the potential, and I think that's another area that needs to be improved upon. Because if you have that patient who's at high risk, has all those risk factors, they're at high risk. So how are we recognizing that potential and making sure that any little change in that patient is identified to mitigate maybe a surgical site infection from developing? Other challenges that we have are people come into the hospital, they're here for a very short time, they're out in the community, and there's little connection between making sure that patient is cared for and preventing a surgical site infection or identifying one early. So in terms of oxygen, there's some conflicting evidence that exists for the use of oxygen. So here's an RCT that demonstrates an increase in surgical site infection rates with the use of that. Another one that demonstrates a reduction. But in 2012, a systematic review identified really no difference in surgical site infection rates between supplemental oxygen and control groups. So while the theoretical arguments to support supplemental oxygen are abundant, additional studies are certainly warranted to make some suggestions as to whether this is a level 1 evidence of guidelines. But this strategy is most effective when combined with additional strategies to improve tissue oxygenation, including this maintenance of normothermia and appropriate volume replacement. So it's not just one thing; it's usually a bundle of things that are going to make a good outcome. So you can see how multiple factors actually start working together within synergy. So in terms of these checklists, if we implement checklists, are they effective? Are they reducing surgical site infections? Well, it's surprising that there's studies that say no, it doesn't make any changes to surgical site infections. One study I found from Ontario that once again, implementation of surgical site infection checklists was not associated with any significant reduction in surgical site infection rates. Here's another meta-analysis, with the World Health Organization checklist, and once again, here's a study that demonstrates that sure, with implementation of a bundled approach, we can reduce some postoperative complications following the implementation. So the evidence is kind of yes, it works in some places, no, it doesn't work. But it's one thing about following a checklist and ticking off things. And when I read further into literature, I found it very interesting that some of these studies reviewing tell us that it's actually about working more together as a team and working, having this team training that's going to make an impact on making sure that checklist is actually getting implemented and improving those outcomes. So here's a study that had a prospective cohort of 600-bed teaching facility, and what they did was they had a 3-session team-based training program when they implemented this surgical site infection checklist. So they talked about things like, talking with people and communication and dialogue and avoidance of obstructive behavior, including silence and violence in maybe some of these environments that maybe are a little hostile. And what they found was having this team training, having people talking together, they compared that to some historical cases where they had a lot of surgical site infections, but with this team training incorporated with the bundle, this is where they saw the outcomes and the improvements in reducing the surgical site infections. So they argued that checklist adoption in isolation is going to fail to maximize the potential impact. So, team training sessions represent a translatable strategy for improving communication and can prevent checklist completion from being something like an administrative task.
How many people have actually worked in the operating room? Just out of curiosity, how many of you work in an operating room? One. How many have never been in an operating room or around the operating room? So almost everybody then in this room is doing something related to the OR. Okay, so no, not really. Okay, right. Okay, not anymore. But you have been before. But right now, things have changed a lot in the operating room in the sense of, for me, a checklist actually has been quite critical to reducing adverse events. Maybe not for surgical site infections in terms of the literature, but definitely for team communication. If you don't do that checklist, or I don't get there and my resident does it, things just don't go as well or as smoothly as they should. The other thing you should know about my day, it starts at 6:30. I'm a plastic surgeon. I do trauma and cancer reconstruction. I have to draw on the patient beforehand. I have to prep them. I go in and look for my equipment. We have a team meeting at 7:30, and then every minute of my time is clocked. The government actually regulates every 5 minutes on what I'm doing. If I have a surgical site infection, it's on me. If I go over 3:30 on my time, I'm docked my OR time. This is actually mandated government regulation, so not just the pressure. I reconstruct skulls, I put arms back on, I'm doing breast cancer reconstruction. I'm not just under the clock for the pressure of being a surgeon, I'm actually timed. And so the time is very important, and it's how they actually allocate. So now you're actually doing a really, really complicated case. You need the support of a really good team, and then I'm under the pressure of the clock. So it's definitely changed the way we practice in surgery, but also probably leads to some of our adverse events, because about every hour on the hour someone's in my OR, are you done yet? Are you done yet? And I can be in a massive bleed, but I'm still trying to answer these questions or being distracted by what we're doing. I found the checklist to be great, especially as a person with an expertise in wound physiology. Normothermia, this is a very, very important paper that was published in 1996. If anyone ever have a chance to go to the American meeting or the Wound Healing Society, this really came out of the society looking at temperature. And temperature is not just important for infection, it's actually important for those fibroblasts and keratinocytes that rely on temperature. Their enzymes have to be at a perfect temperature for this all to work. So it's not just to prevent infection, it's also to promote healing. This was a randomized control trial. They did 400 cases, mainly abdominal surgery cases. So you have to keep it kind of the same, because what I do is really different from a belly surgery. They actually randomized people to actually be cold, so 34.5 or 36.5. And what they found is the infection rate. So if you were normothermics, this is called a normothermic protocol, of which I run in my ORs, as well as in bariatric surgery, very important to run a normothermic protocol. 6% of those patients actually had an infection. These are people with ulcerative colitis. You know they're going to have high risk of infection. The hypothermic group, so if you kept people cold, 19% of those people had an infection. That's huge. What's a huge difference? And all it really was let's keep our fluids warm that we're putting into the patient through an IV and put an arm warmer on them. That's what they had. So it's two interventions. So it's what we call external or passive interventions, as well as internal or active interventions. Big paper, changed the way we think, but still not really adopted by a lot of hospitals. And really, I would say the bariatric program has done it quite well, but we don't do it very well in our other surgical specialties. And I'd be interested to hear from other people, either afterwards or in questions, to see who's actually doing that. With respect to glycemic control, so I'm in the area of diabetes. I make optical imaging technologies for the lower extremity. Glycemic control is a huge thing. I spent 10 years in the burn unit. The minute a burn patient comes into your unit, you are immediately putting them on insulin. Why? You don't care if they're diabetic or not. We know that if your sugar, even if it's not high, it needs to be tightly regulated to control those processes that impact wound healing, as well as multi-organ failure. We're talking about SIRS, sepsis, all those other things. This was a huge study, again, a pillar paper in the medical literature. They looked at over 11,000 patients. They found that 29% of them just on screening were hyperglycemic. If you were hyperglycemic, again, not treated, 2 times the risk of a surgical site infection. So the odds ratio is 2 times more likely you're going to have an infection. 2 times more likely to have another operation. So think about that for the patient. You got a complicated surgery, now you're doing another complicated surgery, and think about the cost in terms of length of stay and the complications associated with that patient. 3 times more likely to die. You were 3 times more likely to die if you had high blood sugars. And this doesn't matter if you had diabetes or you didn't. And that's, I think, really critical. So now going back to your own facilities, start asking about glycemic control. How tightly are their sugars regulated, especially if they're really sick? Also, we talk a little bit about antimicrobial sutures. I don't actually use these sutures. They're very expensive, but definitely in belly surgery, it's a good idea. They did an independent systemic reviews and a meta-analysis, so it's level 1 evidence to show these actually reduced your surgical site infection. So this would be important in high-risk type surgeries. So people who have abdominal surgeries, very high risk. Pelvic and gynae surgeries can be quite high risk. So this would be something maybe where we would strategize to say, hey, maybe we should use these sutures in those types of cases. But again, the cost is really high. Other risk factors with respect to is maybe inordinate personnel traffic during the operation. So I have a team changeover pretty much at all the breaks. So there's a break time, there's a lunch time, there's another break time, and there's a 3:30 if I'm running a long room. And so there's a lot of traffic and a lot of people that are coming and going. Plus, I work at an academic institution. People are coming to watch me operate. So I have all those people also watching me. So a lot of that traffic it can be distracting, but also it may be introducing infection. As well as excessive use of electrosurgical cautery. I'm a plastic surgeon. We are the most meticulous surgeons on the face of the planet. We handle tissue very carefully. However, it really kills me, especially if I'm doing a breast cancer reconstruction, when I see my surgeon take the cautery and cut right through the skin, down through the subcutaneous tissue, and I want to cry because I'm about to reconstruct a breast and they've just killed the surfaces of the skin. I have talked to them over and over again. I still have work to do, but definitely that's been associated with risk for surgical site infection. If you have a prosthesis or a foreign body, so things like hip, knee replacements, again, I'm in breast cancer, so I do a lot of breast implants. These are all high risk because you're putting something in the body. So this is very important to have your prophylactic antibiotics given at the right time, as well as also using what I would call minimal touch techniques. So you have to change your gloves, there's a sterile protocol, and how you prep the site before you put the prosthetic in. The degree of tissue trauma, so obviously a farming accident, so I'm trauma and cancer reconstructive surgeon. If you have an arm that's been crushed in some hay baler, obviously that's going to be high risk for trauma, but also just even the nature of what you're doing to the patient can increase that risk. The need for a blood transfusion, there's reasons for that, also increases the risk. And just surgical innovations increase the risk, and that could just be things that we're doing all the time. Overall, I think, do you want to go back to you? Yeah. Really, it's probably underestimated, our surgical site infections, and I think it's getting back to how we're discharging people so fast. How do you track the people after they leave? It can be related to your surgical specialty. How do we interpret these definitions? How do we have an effective case finding? And we really need independent, unbiased, trained observers, or maybe we just actually need technical tools like the patient monitoring themselves when they go home. And there's intrinsic and extrinsic factors, which we'll get into. We have, are we close to time? Okay, we have some things to say about postoperatively, but we'll just maybe quickly run through them.
Sure.
Yeah.
Okay, so just quickly to close off, in the postoperative period, I mean, the patient is center in terms of assessment and wound assessment, focusing on moist wound healing, any type of early recovery after surgery programs, of course, getting our patients up and moving quickly. We have limited time in our settings, but get to know your patients and implement these as best as possible. Use your diagnostics, or certainly incorporate some into practice. People always want to know about dressings. There's maybe little evidence to say, yes, one dressing is better than the other. Or using a postoperative dressing to cover this incision is better. So there's evidence lacking in that area. Certainly we need some more well-powered controlled trials to also recommend negative pressure wound therapy on a regular basis. So what we know is that bundles are used to standardize care and reduce emissions. Antibiotic prophylaxis is key. How are you taking the hair off, or are you leaving it on? Maintenance of body temperature and skin prep for sure. So the challenge for you is to identify those risk factors, mitigate those risk factors. We didn't talk about antimicrobial stewardship, but that's also another important element. What type of guidelines are you using? Bundles, are we complying with them? Are we watching them? Are we auditing them? But I think most importantly, are we communicating as a team and making sure that we're actually adopting these guidelines into practice? So looking at our culture and looking at process rather than task involving our patients. And of course, we certainly need some more evidence as well. So thank you very much.
We have time for